Okay, hi everyone. Welcome back to another session with Fresh Dental Shadowing. Today we have Dr. Sonkar and she's a periodontist. So yeah, take it away whenever you're ready, doctor.
All right. Good evening or good afternoon, depending on what time zone you are guys attending from. My name is Dr. Jyoti Sonkar. I'm a periodontist and a clinical assistant professor. And today I'm really excited to present you all a bit of tidbits from my journey and a topic on soft tissue grafting. And I really hope you enjoy and it just helps you in your journey to become a dentist. Feel free to leave any questions in the chat, or I would share my contact information. Just feel free to reach out to me if you have any questions. All right, so let's begin. So as you all know, my name is Jyoti Sonkar. I'm a periodontist. I'm also a public health professional. And besides that, I'm also a clinical assistant professor at Boston University, Henry Goldman School of Dental Medicine in Boston, Massachusetts. Talking about a bit of my journey, I was more of a foreign trained dentist because I grew up for most of my life in Mumbai in India. And I pursued my high school, my former dental degree from Mumbai, India. So this is what my dental school looked like. It's situated in one of the most populous cities of Mumbai. And I really enjoyed my time as a dental student because I was exposed to a variety of patients. As you know, India is a huge country with a lot of people. So getting patients was not a challenge, and it really added to my practical skills and helped me improve my knowledge. But then after pursuing my dental degree, I figured that, this is not something I wanted to stop. I wanted to learn more and specialize in a particular field, but at that point, I wasn't really sure what I wanted to pursue. So while I was working in one of the city hospitals, I came across the concept of occupational health safety. And that really intrigued me. This concept really basically talks about environmental hazards and pertaining to healthcare professionals, needle sticks, pertaining to dentists, ergonomics, backaches, musculoskeletal disorders, and whatnot really fascinated me. And that prompted my journey a bit from dentistry. And I decided to pursue a master's in public health in Kent State, Ohio. I moved to US in about 2012, which is almost a decade ago. After shortly working for about a year, I knew that I wanted to expand my horizons and I just wanted to learn more. And here at Kent State, I was able to pursue a degree in environmental health sciences, which is basically a core concentration of public health, where I specialize in OSHA. As and when you would step into the world of health professions, you would understand the word OSHA is really important. It stands for Occupational Safety Health Administration, and that basically deals with how we work, how safe we are, and what measures are we practicing to make sure that our surroundings are safe. And that would include as simple as proper medical waste disposal, making sure that you're not getting cut by yourself with a needle or with some sharp instruments. And there's a lot more that goes into it. Ergonomics, as a dentist, we really bend in unnatural positions that's really impacts our physical health. So things like that, it really helped expanded my knowledge about not dentistry, but the parameters around it. I really wanted a bit more because I was always keen in doing research, and I knew that as a dentist, I didn't just want to practice, but I wanted to be in academia, and that was something. The skill would really help me grow and be where I am today. So after pursuing my public health degree, I moved on to Memphis, Tennessee, to pursue my 1-year AGD. Now, AGD is really a 1 to 2 year degree that basically helps you practice. So it's really beneficial for foreign trained dentists like me who didn't really have any clinical exposure in United States. And I really wanted to pursue, by then I knew I wanted to pursue periodontics, and it's a surgical field. It's really competitive. So AGD really gave me that confidence and closed the gap that I was missing. It introduced me to the world of dentistry in United States and just made me really competitive on paper. And now it's one of the most sought after residencies. It's not a specialty degree, but it just gives you, it's a certificate program. And after COVID, where a lot of students were impacted in the dental school because they weren't seeing a lot of patients, AGD was one of the top ranking residency programs in 2020 and 2021 because students who didn't really get much experience wanted to move on to these residencies and practice, see patients, and depending on where you apply, you might get more expertise in certain skill sets. So Memphis, Tennessee, the program really exposed me to dental implants and a lot of concepts around implants, and that really helped me because I wanted to be a periodontist. And a major part of periodontics is implant dentistry, so this really exposed me to that, and it really added to my worked in my favor and added to my resume and really made me a competitive applicant. So after that, I was able to pursue my degree in periodontics from the very famous and I would say interesting city of New Orleans in Louisiana. I graduated from Louisiana State University. It was a 3-year program with a degree in periodontics, and that's basically how I came to an end to my education journey for now. So what does periodontics mean basically? For those who are interested in dentistry and want to explore different specialties, periodontics is one of the surgical residencies apart from oral and maxillofacial surgery, where a periodontist would work with and deal with the areas of gums and the tissues that hold the teeth together in the bone. We do a lot of regenerative procedures where we try to grow gums, bone, and a lot of dental tooth structure. I mean, a part of the dental tooth structure. I mean, we can't really grow teeth. But we do a lot of these procedures in the event that the regenerative procedures cannot work. We do a lot of reconstructive procedures like dental implants and working with other dentists on implant related prosthesis. So it's a really involving work. And this is one of the photos of me in my 3rd year of residency at LSU. That's Louisiana State University. I'm working with a microscope. So one of the tidbits and a fascinating thing about my program in LSU is that it's one of, at that point when I was pursuing my residency in 2015, it was one of the only residencies in the United States to offer you a microscopic training, wherein you see a patient here and I'm actually doing a gum graft under the microscope. So this is me looking into the microscope and not at the patient's mouth. So it was really cool, and that's one of the reasons why I decided to pursue my residency at LSU. The other factor was that it was really cheap. State universities are really cheap options. So that's something, if you have financial troubles, that's really helped me out. My fees was like $15,000, which is really peanuts compared to other programs where you pay up to like $80,000 to $100,000 a year. So that's another strong reason for me to pursue this residency. And this here is a photo of me teaching my dental students on how to perform a gum graft on pig jaws. So it was one of the very sought after workshops that I would do with my dental students. And this was when I was a professor at Maine. So yes, I did teach at University of New England, Maine, prior to my stint at Boston University. dentistry, and I really had a good time. And this is just me in action, teaching my students on how to go about the basics of gum grafting. So yeah, I mean, if you have more questions about periodontics, feel free to reach out to me. Now, in the meantime, let's move on to the topic that you guys are here for, and that's the topic of soft tissue grafting. Now, just to kind of give you an idea, today we're going to talk about gums, and what you can see here is periodontists they deal more with the gums and bone and not really much with the teeth. What we do is, if there is you see this, how the gums is away from the tooth, exposing the tooth, we deal with a lot of gum grafting and a lot of aesthetic procedures. And I just want you guys to get introduced to the world of gum grafting and what that means, just the basic concepts. I understand you guys are pre-dental students, and there's a lot of lingo that I might throw off that might confuse you. Uh, I'll try my best to keep it as simple and as basic as possible. But at the same time, I want you guys to know that dentistry is so much beyond just fillings and root canals and cleanings. It's much more advanced, much more precise, and there's a lot of plastic surgeries that we do in the mouth. So periodontists are the plastic surgeons of the mouth, where we do a lot of aesthetic procedures. So let's go on. So to give you an idea, why do we do a gum graft? A gum graft is usually done when there is a gingival recession. Now, a gingival recession means gums is known as gingiva in the dental terms. So when these gums move away from the tooth, exposing the part of the tooth, that phenomena is known as a gingival recession. Okay, so if to kind of give you a comparison, this tooth, look at that. You have the gums right at the level of the tooth, level of the enamel. That's the ideal position. But in this situation, you see there is this yellowish part of the tooth that's exposed. And that's not great because it is an aesthetic issue for the patients, and it also causes sensitivity and even cavities. So this is something that as a periodontist, we work commonly. And in a periodontist office, this is one of our breads and butter. I mean, you would see people referring us gum graft cases all the time because with the experts, it's periodontists are the only specialists in the field of dentistry that are trained to do gum grafts. So that's how we would be the one getting all these patients and referrals from all the dental offices. So kind of give you an idea, these recessions are basically classified based on, depending on how severe they are. Typically, a class 1 recession means that the recession is just within the gum line. You see, this is known as a muco-gingival junction. A muco-gingival junction means a junction where your gums end and a mucosa starts. Now, mucosa is just it's not a gum, it's just a loose flabby structure that's attaching your lips to your jaw. So mucosa is just one of those structures that don't really serve any functional purpose. It doesn't help you with chewing and whatnot. So it just is there to just help with attachments of various muscles and lip muscles and structures. Whereas beyond, above this junction is the gum, or known as the gingiva. So when your recession is within this junction, it is known as class 1. A class 2 recession is a bit more severe, where it extends up to the junction. Or sometimes even beyond, but at the same time, there is no loss of papilla. Now, papilla is the structure of the gums that's in between the teeth. So this is the gingiva, this is the papilla that's in between the teeth. So if you see, there is recession, but the papilla is intact. There is no loss. So these are known as class 1 and class 2. And it is really important as a dentist and even as a periodontist to identify the classification, because that shows how easy the gum graft would be and how predictable the gum graft would be. In class 1 and 2, gum graft usually occurs gum grafts are usually successful 100% of the time. So moving on, we do have, I want to iterate a bit more to make you understand what our anatomy means. So as you can see, this is a lower jaw. Lower jaw is known as a mandible. You have teeth, you have the gums all around. So if you can see, so this is known as the gingiva. This is the band. This is the muco-gingival junction. So anything above that is a gingiva. Anything beyond that is mucosa. So the mucosa basically just helps with attachment. And this is a frenum. It's just a fold that you're gonna see, and it just contains muscles and some soft tissue fibers. So as a periodontist, we really help in regeneration and reconstruction of this structure that is known as attached gingiva. An attached gingiva is basically a part of the gums, as you can see, that is firmly attached to the bone. And it's really important. I'm going to talk about that in a minute as to why attached gingiva is really important for a healthy mouth. But I'm just outlining the various structures so you understand, and while I'm showing you the cases, what I mean. So this is attached gingiva. It's just this part. And you can see this small band. It's about 1 millimeter band that's going around. This is also gingiva, but it is just known as a free gingival margin. And the reason it's known as free gingival margin is this entire millimeter is not attached completely to the underlying bone. A part of it is just free. So if you can see a cross section, it's just attached at one point. The rest is just, it's free to move. And that's the reason it's known as the free gingiva or free gingival margin. Anything beyond that, the attached gingiva, the entire gingiva is firmly attached to the underlying bone. This yellow thing is a bone. It's completely attached. So it's not, this part of the gingiva is not going to move. Whereas the free gingival margin may move a bit when you're brushing, when you're eating, or when you're picking your mouth with a toothpick or flossing. It might just move a bit, but this is firmly attached, and both are equally important and has their roles. We'll talk about that in a minute. And then beyond that is a muco-gingival junction, and then the rest is the mucosa. So talking about keratinized tissue. Keratinized tissue basically is a tissue that includes the entire attached gingiva plus the free gingival margin. Keratinized tissue means that this area, the free gingival margin plus the attached gingiva, also contains a band of keratin. Keratin is something, it's a type of protein that's found in your nails, gums, and even on skin, and even underneath in the mouth. And it really plays an important role in protecting the underlying tissues with any insults, like mechanical insults. Maybe you're eating and you're really aggressive, you're eating a pizza, or you're eating something like a pretzel that really slices off or slits off your internal structures. So this keratinized tissue really reinforces them and helps them against these insults. Or if you're brushing too hard on your gums, the keratinized tissue, the keratin really helps protects the layer. And also if you're eating something really hot or something, it just helps you make sure that it just keeps everything protected. So keratin is that's a small layer. It's really dead. It doesn't contain any blood vessels or nerve fibers, but its main job is to just basically protect your structures. You can find a bit of keratin even on your skin. It's just as a protective layer, but it's really important for us to understand the importance of keratinized tissue and what attached gingiva means. Keratinized tissue includes both free gingival margin and attached gingiva, whereas attached gingiva is a part of keratinized tissue. So just keep that in mind, because I'm going to talk about that in a minute. So why am I talking so much about gingiva? Now, the reason I'm talking is because A, I'm a periodontist and that's my expertise, but B, it really plays an important role in maintaining your oral hygiene. We have a lot of literature, and the ones in red are the name of the authors that talk about the importance of attached gingiva. To kind of give you a bit of a more background, attached gingiva varies in length. At some areas in the mouth, it could be as minimum as 1 millimeter, or as large as 9 millimeters. And there've been a lot of studies that show that if your gingiva is less than a millimeter, the area around that tooth will always be bleeding and inflamed and red and angry, which means that the tooth or the part of that area is not able to fight any plaque or any bacteria by itself, because the attached gingiva helps fight off these plaque. So it's really important for us to have attached gingiva at least a millimeter and above, to make sure that the teeth are able to fight off, because these attached gingiva will contain a lot of cells under within them that will help fight against bacteria. So that's one of the really important things, that a tooth really needs attached gingiva. And there have been a lot of studies that show that by Lang and Low, it's like one of the classic articles that says that you ideally need 2 millimeters of keratinized tissue, where 1 millimeter should be attached gingiva, and the other 1 millimeter could be the free gingival margin. So that's like really the ideal. Anything less than that, dentists would refer you to a periodontist that, oh, you need a gum graft, because beyond that, that area will really bleed, and there's going to be a lot of consequences. Whereas on the other hand, we had this another author that felt that it doesn't matter if you have attached gingiva or not, as long as you maintain good oral hygiene, it's not a problem. So there are different schools of thoughts, and what do you think we believe in? I mean, what this guy is saying is an ideal scenario, meaning, yes, if you really are good at taking care of your mouth, and if you have less than a millimeter attached gingiva, it's fine. But honestly, being in this profession for almost 10 years and seeing, there are very little less patients that you're going to see that really maintains oral hygiene. A lot of our patients are ignorant, or sometimes they're trying, but they're not able to maintain. So if you go by that logic, we try to encourage all the patients to, despite keeping good oral hygiene, if we see any keratinized tissue less than 2 millimeters, we do refer them for gum grafting. And that's what I'm going to talk more about today, is what are the different instances when we refer a patient for a gum graft. And I'm going to show you some of my own cases and different techniques of gum grafts, and I hope you enjoy that. So kind of give you a bit more background. I was talking more about the anatomy, a free gingival margin, and then underneath that attached gingiva. Now let's talk about what is a gingival biotype. Now every human, depending on their structure, if they're big, large, or petite, will have a biotype, meaning some patients will inherently have a thicker biotype, and by that it means that your gingiva is more than 2 millimeters in thickness, and some patients by nature or inherently will just have thin biotype. And why is that important? I'll tell you in a second. A thin gingival biotype is basically a biotype which is less than 2 millimeters. Of course, I just told you that. And also, it's important is because if you do any sort of implant surgeries, they're oftenly seen underneath the gums. So that's not really a very aesthetic area. And also, a thin gingival biotype, patients have underlying bone that are more prone to losing. And it's just a nature thing. I mean, studies have shown that these patients, when they undergo any sort of surgery, they are at risk of having complications, because the underlying bone is just really thin, and they really tend to have complications after gum grafting or implant surgeries or something. So this is something you need to consider prior, and let the patient know beforehand, but when you're doing a surgery, that this could be a complication. It also helps you decide certain procedures. You might not want to do some risky, adventurous procedures, and maybe just want to stick to basics in such patients. So once you get into dentistry, you're going to learn a bit more about what I'm talking, but this is just the overall idea. A thin gingival biotype also include patients that have longer teeth, which means that if your teeth are longer, which means your papillas are longer. Now, in the event if these patients have gum disease, the papillas are the first one to lose, and they're really hard to fix. So that's another importance. And such patients could be challenging as a periodontist for us to decide what kind of aesthetic surgeries we want to do, and we really have to keep the biotype in mind. On the other hand, a thick gingival biotype patients will have squarish teeth, a shorter papilla, and their underlying bone is really thick, which means they're less susceptible to any complications, and they're more predictable to have better outcomes after a surgery. Now, this is you would say that, oh, this is really unfair for someone who might have a thin gingival biotype, but I understand, but this is what it is. So this is something you really need to assess in your first appointment when you're talking to your patient. So as a periodontist, that's one of the things that I would take a look at, talk to my patients, let them know that this could be a complication, and that you're a thin biotype or you're a thick biotype. I would kind of explain what that means and how would those things implicate in the surgery. It just really helps us prepare the patients and helps us in treatment planning a case better. So with that being said, so we talked about what a gingival recession is. We talked about basic and anatomical structures. I kind of gave you a basic idea about what gingival biotype means. Now, when would you want to do a soft tissue grafting? A soft tissue grafting is just a fancy word for gum grafting. When would you want to do that? If you're a dentist and you see some scenarios in the patient's mouth, when do you think you would want to refer the patient to a periodontist? Now, this is when you want to do is when you see a patient that has a recession and has no keratinized tissue. Remember why I talked about a keratinized tissue? Because you really need keratinized tissue. You see this recession is going beyond the mucogingival junction, and there is no band of free gingival margin or attached gingiva. And this is not a good situation, because what's going to happen, since this tooth lost the overlying gum, it's going to lose the underlying bone. And all these teeth are usually fixed in the jaw by the bone. So if this recession keeps increasing, this tooth is going to keep losing more bone, and it's going to end up getting loose. And what's going to happen if it gets loose? Eventually, this tooth is going to fall out, and that's not a very good thing for the patient. So when you see a situation where you have a recession and there's no keratinized tissue, you immediately refer the patient to your periodontist to get a gum graft and to save this tooth. I mean, there's no other way you can save the tooth. You can't put any cement or filling or anything. It needs a gum graft because it's missing a chunk of a gum. And I'm going to talk about situations where you end up being in this position and what are the different reasons where you can have a recession. The next thing when you have is you do have keratinized tissue, but it's not adequate, meaning it's less than a millimeter. So what happens when you have less than a millimeter? So assuming 90% of our patients are not really good at keeping their mouth clean, what's going to happen when your keratinized tissue is less than a millimeter? The tooth is going to be consistently bleeding when the patient is brushing. And if patient has a thin gingival biotype, then that's even worse, because a consistent bleeding means that the tooth is really aggravated, it's really inflamed, red and angry. And the more you brush, the more you eat any hard food, the area is going to keep getting irritated, and eventually that recession is going to keep increasing. And from inadequate keratinized tissue, you're going to get to lack of keratinized tissue. So that's again not a good thing. So you don't want to wait till this situation to happen. You want to send the patient when the situation is less severe, because if the disease is less severe, the outcome is much more predictable. If the disease is really severe, the outcome could be compromised. You don't want to wait. You want to let the patient know when you're seeing a patient for regular checkups that, oh, I do see that this particular area, the recession is increasing. In the last visit, it was about a millimeter in length, and now it's 1.5 millimeters. The recession has increased, and that's not a good sign. Maybe you want to see a periodontist and get that fixed. So this is one of the reasons when you would refer them to us. The other area is muco-gingival defect. A muco-gingival defect occurs when there is some amount of keratinized tissue or attached gingiva, but it's not completely attached to the bone. As I mentioned, an attached gingiva is firmly attached to the tooth. As you can see, this instrument is going beyond the muco-gingival junction. It's going into the mucosa, and that's not good, which means there is a recession, there is some keratinized tissue or attached gingiva in this case, and this attached gingiva is not completely attached to the bone because the instrument is going past it. So that's again not a good sign because the tooth is going to suffer eventually. So in that situation, you want to refer them to a periodontist. And then the other problem is this frenum. As you can see, we all have frenums. It's a fold of muscles. Usually you can see in the lower midline, upper midline, and like around in this area of the mouth, around in the corners of the mouth. And it's just a naturally occurring phenomena. Sometimes what happens is this frenum is really attached super high than they're supposed to be, and what happens is they pull on this attached gingiva and the free gingival margin, and the constant pulling will lead to recession. And by pulling, I mean that when you're moving your mouth or holding your mouth or brushing or eating something, your lips are getting stretched out, and that causes the frenum to pull on these gums. And a lot of times, a frenum can cause a recession too. It's not very uncommon. It's not very common, but it's not really uncommon as well. I mean, I would see these patients with aberrant frenum, meaning the frenum is really not in a normal position. It's really high, causing recessions. So we usually see younger patients who are going for braces to an orthodontist clinic, and we have an orthodontist referring those patients to us because they have this aberrant frenum. So in that case, we would need to do some sort of a gum grafting procedure and move this whole thing down away from the gums. So with that being said, I did tell you some cases that leads to that requires gum grafting. But what are the other inherent factors that can cause patients to have recession? Patients can have a recession if they have thin buccal plate. Now, one of the reasons could be thin buccal plate is because patient has a thin gingival biotype, or it could also be because of any trauma. Patient was in an accident or just had any injury where there was some fracture of the jaw, and that could lead to reduced bone plate thickness. I mean, this is a tooth. This is your lower mandible or a lower jaw. And you look at the bone in front of this tooth. Over this is where you have the gums. So if your bone is really thin, and let's say if you're brushing really hard, you're scrubbing away your gingiva, what's going to happen to the underlying bone? It's really not going to be able to sustain that trauma. It really needs to be at least 1 to 2 millimeters in thickness. So if it's less, these patients might have recessions more fast. And then some patients have an inherent phenomena known as dehiscence, where they just don't have bone. They might have overlying gums, but they just don't have bone. And that's the phenomena known as dehiscence, where the patient don't have underlying bone, but has gums. And eventually, when you're brushing, you're traumatizing the gums. That's going to lead to recession. There's no way of you knowing presence of dehiscence because you're not really be able to gonna see the bone when you're looking or in the patient's mouth. The only way we come across dehiscence is for whatever reason we're taking a CT scan, maybe because we want to plan an implant in some other area, but we take a CT scan of the whole mouth and then we happen to see, oh, there are other areas in the mouth that has dehiscence. So we let the patient know that we want to although we want to put an implant up on the top, but we see some teeth in the lower in your CT scan that has dehiscence, and you might develop a gum gingival recession in that area eventually in the next few years if you don't be careful. So that's how usually we let the patient know beforehand. And sometimes it's tooth positioning. Let's say if one of your tooth is really high coming out of the mouth, what happens when the tooth is moving forward and it's malaligned or it's just malpositioned? It affects the bone. If a tooth is really malaligned, it will impact the overlying bone, and that might lead to reduced bone plate thickness, and that will make the tooth more susceptible to gingival recession. So this is something you want to keep that in mind beforehand, and talk to the patient before a patient develops a recession. As you can see in this area, I mean, it's all crooked teeth. They're all malaligned, and you can already see some recession forming. This is a recession, this is a recession, this is a recession. So what causes recession? One of the top two factors is bad oral hygiene and gum disease. They really they lead to um, trauma to your attached gingiva, and they lead to have more recession. So all of these things are classic articles that actually have it's evidence-based knowledge that talks about how people with bad oral hygiene and gum disease are more likely to develop recession. And then again, the next reason would be patients who've had some gum surgeries, not necessarily gum grafting, other surgeries like osseous surgeries, gingivectomy. I'm not going to dive deep into it because that's like a different topic in itself. There's a lot of other things that we do besides gum grafting. And sometimes, as a side effect of those surgeries, you might end up getting some recessions, and that's totally normal. And we let the patient know beforehand. And it's all about weighing pros and cons. In a scenario where we're doing other surgeries that would lead to recession, the reason we do it is because we have to. If not, then we end up losing multiple teeth. So instead of losing multiple teeth, we do surgery and have some recession, and that should be okay. So sometimes we have to make that call. So if patient has any periodontal treatment, you might see some recession. And then you also see recession with age. It's a normal wear and tear of your body. I mean, at some point you're going to grow old, your joints are going to hurt, you're going to have issues with your health, because that's normal. It's normal wear and tear. So after age of 30, having one or two recession in the mouth is totally normal, and you don't really have to graft every recession that you see. You only graft if that recession is accompanied by consistent bleeding or consistent increase in the recession, or that area is just always red and angry and causing sensitivity to the patient. But if you see some recession that's really not causing any issue, just let it go. Just wait and watch, because it's normal. After 30 years, you're going to have some wear and tear of the mouth, because I mean, we eat every day, we talk every day, we brush every day. There's going to be a lot of wear and tear happening in the mouth any which ways. So it's totally normal to have a few recessions here and there. And the next thing is, one of the very common causes of recession is brushing. The brushing factors that are associated with the recession is how frequently. I mean, ideally, we say brushing twice a day should be good, but you will find some overzealous patients that are brushing like, I don't know, 3 to 5 times a day. Excessive brushing is really bad. And your technique, if you're brushing incorrectly, that's going to cause recession. And then force, if you're really using a lot of force and really like scrubbing your mouth away, that's going to cause recession, because gums at the end are really delicate and gentle. I mean, they have keratinized layering, but there's only so much it can bear the force. You don't really want to be too hard. And then also depends on the hardness of the bristles. Older generation people tend to brush with hard bristles, because they feel like if you're not brushing with something really hard, your mouth is not going to be clean. But that's not really the actual science. It's the technique of cleaning, not how much force you use. So if you're using hard bristle brushes, that will cause recession. So remember, you want to ideally use soft bristle brushes. It's not the hardness of the bristles, it's really the technique of brushing that helps maintain your mouth. So any of that factors will cause recession. And this is one of the really common factors that you will see in your dental patients, that bad brushing style leads to recession. And the next factor is tongue piercing or lip piercing. Any sort of piercings in the mouth will constantly rub against the gums, depending on if your tongue's pierced, so your inner side of the gum is going to have recession. Or if your lips pierced, the outer side of the gums is going to be associated with gingival recession. So just keep in mind, these are some of the reasons that might cause recession. And depending on what causes a recession, you might want to make that call if you want to refer them for a gum grafting. With that, let's show you some of my own cases. These are my own cases that I did as a periodontist. This is one of a really sweet patient. The patient was a teen patient that was about to undergo orthodontics, meaning he wanted to go for braces. But if you see this tooth, it really had less than a millimeter keratinized tissue. So the orthodontist referred me that he really needs a gum graft. So what we did, we added a patch of gums. Now again, it's not really aesthetic, but we do this kind of free gingival grafting in the lower area where it's when you smile, the lower area is not really seen, and it's one of the really predictable options. So this is how we were able to increase the keratinized tissue. So from 1 millimeter, this is basically your mucogingival junction, can really outline and see, but it's really less than a millimeter. And if he had undergone ortho, this would have been really bad for that tooth. So the orthodontist really wanted me to increase to at least 2 or 3 millimeters. So from 1 millimeter, we were able to increase like 7 or 8 millimeters. And the rest of the teeth has good amount of keratinized tissue. But these two teeth, we were able to increase. I mean, you can say not a really aesthetic patch, but it works. It helps the patient, and it's not really seen when you're laughing or you're smiling or you're talking. The next case is again a gum graft that I did. Now in this case, I took a piece of a tissue from the patient's roof of the mouth. So this is the patient's own tissue. Now in this scenario, I didn't use the patient's own tissue, but I used a material known as Muco-Graft. I'm going to talk about it in a second. Now this patient has a lot of recession, has limited keratinized tissue. So I wanted to increase the keratinized tissue from 1 to obviously 4 or 5 or even I don't know, 7 millimeters, which I was able to gain. But look at this. This is so different than this site. Here you can see the difference, but here it just blends into it. So this is another option that you could do. And this is known as a muco-graft. A muco-graft is not basically a patient's own skin. It's basically a xenograft. A xenograft is it's derived from pigs, but it's not a tissue directly derived from pigs. It's basically a skeleton that's derived from pigs that has a lot of cells. But what it does is it's basically it has a skeleton matrix that blends into your own gums when you add to the area, and it regenerates and remodels into the patient's own gum. So it's a very good option for someone who doesn't want to use their own tissue, because it's another surgery. So let's say if I want to do a gum graft here in the chin, I might have to take the tissue from the roof of my mouth. So there's 2 different surgical sites, and sometimes patient don't want to do that, or sometimes patient just doesn't have good quality tissue. So in that event, we use xenografts. Xeno meaning derived from non-human species. This is basically autograft. This one is an autograft or autogenous tissue. Auto means your own self, tissues from your own self. Xenograft meaning from non-human, which ideally is animal species. So in this case, it's a pig-derived matrix. So what it does is it just sticks around in that area, stimulates your surrounding tissues to grow and get transform into their own gum. So it's really cool science behind it, and it's one of my go-to in the event if I can't use patient's own tissue. The next is again a free gingival graft where I took the patient's own tissue. So this is a bit more vividly I can show you because I have pictures. Now this was the area where patient had limited keratinized tissue. So what I did, I took a piece of the tissue from the patient's palate. Palate is the roof of the mouth. It's on the upper jaw. I took a piece out from here and I put some sponge. Now this side will heal in about a month. Will heal back, and this whole gap that I was created, it will just heal. I took this tissue out and I added it here. So as you can see, compared to this area, look at this, how we've been able to increase the gum graft here. Now you see that the recession hasn't been solved. Now this is not a class 1 or class 2 recession. As you can see, the papilla is missing. So in this scenario, we will not be able to completely 100% cover the recession. This is a class 3 scenario where you're going to get partial coverage of the recession. But the goal was here to not really fix the recession because it was a lower teeth. Patient didn't really care if the recession was seen. Um, what problem the patient had was that the area was constantly bleeding, trapping plaque and causing irritation to the patient. So we wanted to increase the keratinized tissue here. I mean, I would have loved to cover the recession too, but as you can see, it's a class 3 scenario. The papilla is not complete. There's some part of papilla missing. So you're not going to get complete coverage. So this is why you really have to recognize the case early on before sending them to a periodontist. You don't want to wait for a condition to get severe, because if it gets severe, then this happens. The surgery is compromised. You might not get complete coverage, but you might just get some keratinized tissue back. So we do this all the time, and we just let the patient know beforehand. And as long as patient's okay, and again, it's a lower teeth, it's not really aesthetic. You can't really, the people can't really see those areas, those black triangles, those open spots. So it's okay. So this is just a comparison. There's 2 surgeries that I did. A muco-graft and autograft was done on the same patient, but in 2 different areas of the mouth. The muco-graft was done more on the left side, as you can see, and an autogenous graft was done on the right side. The difference that I want to say is that even though muco-graft was much more comfortable for the patient, in terms of the tissue quality, your patient's own graft is the best quality, just because you can see how it's pink, it's mimicking the patient's own gums compared to this. I mean, it's also mimicking the patient's gum, but it's not clinically as strong as compared to patient's own tissue. But that doesn't mean that I would not use muco-graft. Like if autogenous graft is 95% successful, muco-graft is anywhere between 91 to 95% successful. It's not as great as your own tissue, but in the event if you don't want to go through another surgery, or you don't have the roof of your mouth doesn't have good quality of tissue, you can always still go back to muco-graft. It's not going to be as great as your own tissue, but you know what the hell, I mean, you can, it's still an option you can offer to your patients. So just for you to know the difference between patient's own tissue versus patient's xenograft. Your own tissue is the gold standard. Now let's go to a different kind of a grafting technique. Earlier, I just took a piece of gum. So that's known as a pre-gingival graft. It's less aesthetic compared to connective tissue graft, where I take the underlying connective tissue. So as you can see here, patient has a recession. But look at, I did a surgery here 1.5 years later. Look at this. It's just resembling the patient's own tissue. It's much more aesthetic. Now, a connective tissue is basically a free gingival graft where I take the graft, but I shave off the overlying keratinized tissue, the keratin, and I only take the underlying connective tissue because it's much more aesthetic. But it's really technique sensitive for a periodontist because it requires much more precision and skill. But we tend to do these connective tissue grafting in an aesthetic area, especially in the upper area where when you're smiling, your gums are seen. So as you can see, we were able to fix these recessions here. These are small, tiny recessions that we were able to fix, and patient just loved her new gums. It's not as ugly as something like this that I showed you. Sorry, something like this. I showed you like a weird patch in the middle, but it's much more blending to the patient's own surrounding tissue when you compare with the before picture. Now, this is the other side of the same patient. Patient had some keratinized, lack of keratinized tissue, recession. We did the surgery. This is like 4 weeks after the surgery. It's still healing. And then we were able to fix. Patient has this really, like really good tissue that's much more aesthetic. Now this is a full mouth picture. So here you can see this is pre-op. You can see these recessions. There's a recession, there's a recession. This is like a ugly cement. So we were able to fix all of that with gum graft, more precisely connective tissue graft, because it's much more aesthetic. And when patient smiles, you're not going to see some weird, ugly patch of gums. It's just going to be what the patient's gum is like. So that's another type of technique that I wanted to introduce to you. The other technique that I wanted to talk to you about is connective tissue graft. But in this situation, I mean, the patient sure has a recession, but patient had also underlying caries. So if you look at this tooth, this patient has this cement that's been there for a long time, but underneath the cement, patient had a lot of decay, and that decay went past the gums. And patient had some medical condition, so we couldn't pull the tooth out because that was just not indicated because of that medical condition. So we tried to save the tooth. So this was an interesting case where I worked with a dentist. The dentist was able to remove the cement, remove all the underlying underlying cavity that was causing issues to the patient. And at the same time, patient had recession, patient had lack of keratinized tissue. So I also wanted to do a gum graft before the dentist would put back the cement. So in this scenario, when you have a cement that's going past the recession, you always want to do a gum graft first and then do the filling. So here, what I was able to do, I did a different technique. Instead of peeling out the gums completely, I created a pouch. Now, it might not make much sense to you, and that's okay. You're still pre-dental students. There's a lot more you're going to learn when you get into dentistry. There's different techniques where you completely expose the bone, peel the gums off, and then stitch it back, or you do this pouch technique where the gum is still connected here at the papilla, but I've literally cut off everything else. And that's one of the techniques I wanted to do because the patient was medically compromised. I didn't really want to expose everything out in the open. I wanted to be as minimally invasive as possible. So in that area, I did a pouch technique. I slid the gum graft, the connective tissue graft, and I took the connective tissue graft from the patient's palate. Palate meaning the upper jaw, the roof of the mouth. I took a piece of the connective tissue out, I slid it underneath, and I stitched it. So this is a tooth here. See, the tooth is still missing the cement. You don't want to do the cement before the surgery. You always want to do after because you want to see how the gum grows and how better it covers the recession. So this is like 4 weeks after the surgery. The palate, as I mentioned, healed in about a month, in about 4 weeks. There's a small scarring, but that scarring will go away because this is just 4 weeks. In about 3 months, 6 months, that scarring is going to go away. And even if it didn't go away, I mean, you're not going to be able to see the roof of the mouth. What the hell? Patient's not really gonna have any problems or any functional issue. But ideally, the scarring, the small one cut, goes away in about 3 to 6 months. And here at 4 weeks, look at this. There was a recession before, and now it has a nice pink keratinized tissue healing. You want this gum to grow first before you put the cement, because then you're not going to know how the gums are going to grow if you put the cement before, and you're going to hamper the healing. So always do that. So after we were able to do it, my dentist, Dr. Chang here, was able to put the cement. So look at here now. You could see this dark lines. That was cavity. That was the decay that was causing trauma to the tooth. And there was also a small tiny recession. But now if you see here, the cement is all nice. We've able to fix the cavity, take all the bad stuff out, and we were also able to fix the recession. And voila, patient was able to keep the tooth. Earlier, patient was referred to me for an extraction and put a dental implant. But somehow we were not able to do that because she didn't have the clearance from the doctor. So we were able to do something really minimally invasive, and we were able to save the tooth, and we were really happy. So with that, we'll move on to our last case. Now this is the lower jaw, and patient is literally missing all the teeth. But what patient is planned for 2 implants around here. I don't know if you can see. This is like this thin biotype patient has 2 implants, and once the implants heal, these implants are going to get connected to a denture, and patient is going to have an implant supported denture. Now, why is the patient referred to a periodontist? If you can see, patient has very limited keratinized tissue. So even if you don't have teeth, you still have some keratinized tissue on the ridge, and you need keratinized tissue because once these implants are exposed and this area doesn't have keratinized tissue, that site is constantly going to be bleeding. because that's the area where the implant is connecting to the denture, and food or anything might get stuck in that area. And if you don't have keratinized tissue around those implants, it's really going to be bad for that implant. You can even get a recession on the implant, and if you keep getting recession, your implant will get loose because your implant is covered with the bone, and over the bone you have the gums, and you need keratinized tissue for that. So the patient really had very thin biotype, and you can literally see this, the darkness of the implant showing underneath. So what I did, I was able to look at that implant. It's basically, that's the implant here, and you ideally don't want that to be seen. So again, I took this big tissue from the patient's roof of the mouth. I split it into two, and this was the implant when I exposed it. After it was healed for about 3 months, I added this thick keratinized tissue, and look at that. Now it has this nice thick band of tissue around it, and over this implants is where you're going to get the denture fixed. So patient is basically going to have a denture with the implants. So this is one of the other things that we do a lot in our practice. Patients that undergo implants, sometimes we have to do a gum graft around it, not just natural teeth. So I hope this makes sense. So this is how it looked before, like really less thin tissue. And now after that, I was able to expose the implant plus add some gum graft around it. So it's still healing because it's still a month and a half. This gets much better 3 months, 6 months after the surgery. It just blends in. And yeah. So with that, we're done with our topic of to graft or not to graft. Feel free to send me questions. If you'd like to talk to me, I do have an Instagram page, Perio Nerd, where I not only post my own surgical cases, I talk about dental applications, how to prepare for getting into dental schools. So if you're interested, please like and follow it. It really helps to make me build more content and just pass the word around. I talk about different topics like national boards. Do you have to take it? And this is more applicable to foreign trained dentists who are moving to this country and want to pursue dentistry. You want to take national boards before. And for pre-down students, you don't have to worry about this just yet. You just want to take your DAT, get into dental school, and then you should be taking your national boards in your third year or final year of dental school. So I talk about all of those. I talk about tidbits on how to apply to dental schools, dental school applications, CVs, what kind of experience do you need. So I do touch base a lot of topics. I commonly post at a constant interval. And besides that, I do post a lot of surgical cases of periodontists field. So if you're interested in any of that and want to learn more, please feel free to follow and check out my Instagram handle. And if you have any questions, please let me know. And just one more slide. So this is my Instagram handle. You can even follow me on Facebook, where I post a lot more information. And that's my email. Again, if you have any questions, I get a ton of emails, but I try my best to answer you. So if I don't answer right away, I will get to you in about a week or so, because I keep getting a lot of emails through my Instagram and through my presentations. So if you ever have any problems, just reach out to me. I'll try my best. Might not be right away, but I will answer you eventually. And with that, we're done.
Okay, all right. Thank you so much, Doctor. That was an awesome presentation. So I think we can start with our questions now from the chat, if that's okay with you.
Yeah, sure.
Okay, so the first question was, what's the correct way to brush your teeth in order to avoid recession?
Now, this is something you would have to check it out. I'm going to tell you the name, Modified Bass Brushing Technique. It's basically a technique where you keep your brush 45 degrees, partly onto the gums and partly onto the tooth. You go around in circles, 3 teeth at a time, and then you sweep it down. So when you sweep it down, it basically pulls all the gum, all the guck, all the bad stuff that's stuck between your free gingival margin and the tooth, and it flushes it out. Now it's going to be really difficult for you guys to imagine. So just go on my Instagram page. I have put a link for a modified brushing technique, or you can just YouTube it. That's one of the things that that's one of the most ideal ways to brush. Okay, so
yeah, that makes sense. And then these questions were kind of about your journey. So what factors do you think went into choosing like your dental residency program for AEGD or periodontics?
So AEGD for me was more of a way to improve my resume, just because I was a foreign trained dentist. And periodontics is a surgical residency. A surgical residency is really competitive to get into. And as a foreign trained dentist who had never practiced in the United States, AEGD really helped me understand a better perspective. I mean, I knew I practiced dentistry in India, but I really didn't know much about the United States. So it just helped me get that gap in my skills. It also helped me realize that I wanted to do periodontics, and I didn't derive much pleasure by just doing fillings and root canals. I wanted to do surgeries, and I just fell in love with periodontics while I was treating patients. So that's how I decided to do AGD. Now, perio was because as I just mentioned, I didn't really enjoy fillings and drillings and root canals. So just the surgery aspect of periodontics really caught my attention. And that's how I decided to follow that. And I'm so happy and I'm blessed that I chose periodontics.
Okay. And then have you had any patient cases where you've had to work with an oral surgeon, and what does that process look like?
So we don't really much work with oral surgeons because most of what oral surgeons do, we are trained to do ourselves. But obviously, oral surgeons are much more trained at a much deeper level. So there's certain things that we can do, like skull fractures and whatnot. Those cases will be going on to the oral surgery. But any other surgeries in the mouth, like adding gums, implants, bone grafts, we are much more trained to do that ourselves. But anything beyond that, um, when you talk about facial structures like any bone fracture, jaw fracture, that level of deep cases are seen by oral surgery.
Okay. And then someone asked, what are some differences between like dental school in India and then dentistry in the US?
I mean, it's different in a lot of aspects and different concepts of teaching. The products that we use were not as advanced compared to what United States have. I mean, microscope is just starting to get popular in India, but United States had microscope like 20 years ago. So there's a lot more advanced techniques that I didn't really get much focus on, and just infrastructure. And I mean, the dental schools in the US have more money from the government, so they're just better equipped. Everybody has their own dental chair, and they just have so much better infrastructure support that I didn't much really have in India. So.
Okay. Thank you so much, Doctor. Those are all the questions we had. And yeah, we really, really appreciate your time and all of your responses.
Thank you so much. So yeah, feel free to reach out to me, check out my page on the Instagram, and see if you have any other more questions. Send me a text on Instagram, and I'll be more than happy to answer it. Well, thank you all for listening.